Welcome back to part two of clinical reasoning for the psychiatric mental health nurse practitioner. In this session, we're diving deeper into those tricky scenario based questions that always seem to have more than one right answer. You know, the ones where you can argue both sides. Remember, that's exactly how the boards are designed. They don't just test memorization, they test your clinical reasoning. So as we go through each case, think like a provider, not an RN. What's safest? What's most therapeutic? And what would the boards consider the best next step? Even if in real practice you might do something slightly different, grab your notes, think through each question, and don't be afraid to debate the answer with yourself. That's how you sharpen your clinical mind for exam day and practice. Okay, we're going to jump right in with the question that I'm curious to know if you know the answer to. In evaluating a client for insomnia, which of the following is most consistent with a presentation of transient insomnia? Now, let me stop here by saying if you don't know what any of this means, like transient insomnia, that's okay. Maybe make a note in the comments that that's a topic I could discuss further along in the series. Or if you feel like this question is way too in depth for a beginning question, there's a reasoning behind my logic here, okay? So bear with me. So, remember in the presentation yesterday, I said when you're looking at these questions, begin at the end of the question. So, in evaluating a client for insomnia, which of the following is most consistent with a presentation of transient insomnia? So, at the end of this question, we want to know which is a presentation that you see most often with transient insomnia, right? We don't want to forget all the rest in evaluating a client for insomnia. We want to know which of these you're going to most likely see with transient insomnia. So the choices are A, narcolepsy. And again, if you don't know what this is, we will go back and discuss that. But if you are an RN taking a psych mental health nurse practice exam or any exam that has to do with nurse practitioner, any of those exams, at this point, you should know what narcolepsy is. No judgment. I'm just saying you should know what that is at this point. That's choice A. Choice B is hypersomnolence disorder. C is sleep apnea, or D, usually caused by stress, jet lag, or physical environmental concerns. Now, remember what I said. I'm going to give you the correct answer, and I'm going to give you why each of the answers are incorrect. So let's just start with A, narcolepsy. Narcolepsy is a neurological disorder that's characterized by sudden, uncontrollable sleep attacks, not short-term insomnia. So that helped you also answer if you don't know what narcolepsy is, right? B, hypersomnolence disorder. That usually involves excessive sleepiness despite adequate sleep. That's the opposite of insomnia. Also, let me remind you here, remember that you can always rule out one of these answers as being absolutely wrong, and most of the time, two of them, which is going to give you a 50-50 chance of getting them right if you can do that, okay? C, sleep apnea. Sleep apnea is a sleep disorder that's usually due to a medical condition that's caused by another health issue. Not transient stressors. I'm sure that most of you have heard about sleep apnea studies, those kind of things. So the last choice is D, usually caused by stress, jet lag, or physical environmental concerns. Ding, ding, ding. That's the correct answer. So transient insomnia is short term. It usually lasts less than 1 week. and it's commonly triggered by temporary stress, travel, or in environmental factors like light, noise, or temperature. So it's going to help you to remember that transient insomnia is usually about 1 week. Short-term insomnia is about 1 to 3 weeks, and chronic insomnia is more than 3 months. And so the treatment focuses on addressing the underlying stressor and using sleep hygiene techniques, not medication as first-line therapy. Also, let me give you another little trick here. You notice how D's is the longer of all the four answers? That's not always the case, but if you have a longer answer, pause. If you're totally unsure, maybe you should go with the longer answer. That's just a little bit of clinical insight if you totally don't know the answer. Okay, we're going to move on to another question about insomnia. Insomnia in children is most often caused by. So let's look at the answers. A, excessive caffeine intake. B, family stress. C, neurological dysfunction. D, chronic respiratory illness. Now I'm going to pause and give you a moment to think about the correct answer. And remember, this is where I think you should write it down, just a thought. So if you do not get it right, we can go back and talk about why you didn't get it right. So let's start with the rationale, starting with A, excessive caffeine use. While caffeine can contribute to difficulty falling asleep, it's not the most common cause of insomnia in children. Caffeine use tends to worsen existing sleep issues, but it rarely causes them independently, and especially in children because they don't usually drink a lot of caffeine. So that would be one of the ones I would put on the back burner because I'm sure you're thinking Pepsi, Coke, Mountain Dew. B, family stress. If you picked that answer, you are correct. In children, insomnia is most often related to psychosocial or family stressors, such as parental conflict, inconsistency in routines, divorce, school anxiety, or emotional distress. Stress affects sleep initiation and maintenance through increased arousal and anxiety. C, neurological dysfunction. Neurological disorders such as ADHD or epilepsy, they can contribute to sleep problems, but they're less common. They are less common cause of insomnia compared to the environmental or the family related stressors. Now, do you see how that could possibly be an answer? So that would be one of those like 50-50. And then D, chronic respiratory diseases or chronic respiratory illnesses, I should say. Conditions such as asthma or sleep apnea, they may disrupt sleep, but these are classified under sleep disorders due to a medical condition, not primary insomnia. And keep that in mind. I was wondering if anybody would think that that is where you would talk about your medical illness, not your psychiatric illness. Now, this is where you're going to start thinking like a psych MP and not an RN. In children, behavioral and environmental factors are the most common contributors to insomnia, and your management should begin with establishing a bit of a time routine, addressing the stressors, and teaching good sleep hygiene before considering medication. Okay, this next question, I think most of you are going to get right because we are trained to do this as RNs. So, but if you don't, it's okay. It's okay. So, but let's just see how we do. A psychiatric mental health nurse practitioner is working with a woman whom she suspects is in a violent domestic relationship. The client denies this and refuses to discuss her home life. They continue to present at the clinic for treatment of minor injuries and always is brought by her boyfriend. The client refuses to discuss abuse as a cause of her injuries, simply stating, "I am clumsy." The best initial intervention for the psychiatric mental health nurse practitioner to take is, now I'm going to leave this question up here for a minute for you to look at again. Remember what I said? We start at the end. So the best initial intervention for the psych MP to take is. So we got all this information up here. We're at a clinic. We're suspecting domestic violence. She continues to come with her boyfriend always at her side, or husband or spouse or whomever. And the client refuses to discuss abuse as a cause of her injury, stating she's clumsy. So the best initial intervention, so let's start there. Okay, that's what we're looking for. A, confront the client about the likelihood of domestic violence. B, spend a long time with the client building a trusting relationship. C, report the suspected abuse to law enforcement immediately. D, contact the client's boyfriend to discuss concerns about her safety. So if we look at this, what is the first answer out of A, B, C, and D that you're going to say, I know is not correct? If you said D, contact the client's boyfriend to discuss concerns about her safety, you're 100% correct. And we know we wouldn't do that because that could put her in further danger. And also we know that when a abusive whenever someone's in an abusive relationship, the time that the violence is most likely to escalate or even into death is when the spouse or the significant other is trying to leave. So the last thing we want to do is contact the client's boyfriend to discuss concerns about her safety. So let's look at what is the correct answer. Let's just go with that. B, spend a long time with a client building a trusting relationship. Now, here's where the RN and you might be saying, especially if you're an RN in an ED department, Robin, how am I supposed to spend a long time with a client building a trusting relationship or in the ED? We are not talking about being an RN. We're talking about being a psychiatric mental health nurse practitioner. And as a psychiatric mental health nurse practitioner, we're working with these patients for a long time, and we do have time to build a trusting relationship with them. And even if they're only in our office one or two times, and their abusive partner tells them they can't come back, we still might have that window to build that trusting relationship. So B is the correct answer. So when abuse is suspected, but the client's not ready to disclose, the best initial step is always to build rapport and trust. The client must feel emotionally safe before revealing sensitive information. And over time, consistent, non judgmental support helps the client gain confidence and openness to discuss abuse and accept help. So let's go down to C. Report the suspected abuse to law enforcement immediately. If you thought of that one, and I can see why you might, let me remind you. Again, we're Psych MPs, not RN, but either way, an RN, a Psych MP, mandatory reporting applies to child, elder, or a vulnerable adult abuse situation, not competent adults who deny abuse. Reporting without consent could violate confidentiality and increase danger for the client. So we are not a mandated reporter for domestic violence situations. And then D, contact the client's boyfriend to discuss concerns about her safety. This is never appropriate. This action could escalate violence, endanger the client, and violate their confidentiality. The first goal is always to ensure psychological safety and establish trust. And the psychiatric mental health nurse practitioner can gently provide education on domestic violence. They can give resources and hotline information discreetly while continuing to build rapport. And that's what I meant by even if you're with them only one or two times. If the client later discloses abuse, the PsycMP then can help with safety planning and referrals to supportive services. A 67-year-old man presents to your outpatient clinic with complaints of difficulty sleeping, decreased desire for food, and lack of interest in volunteering activities and going out with friends. The patient describes difficulty in completing tasks due to fatigue and overall ability to focus. Look that over. We have a 67-year-old male. He's presenting to your clinic, and here are his symptoms. Some of his symptoms. So, this part, which of the 5 SIGI counts is the patient exhibiting? So, if you do not know what SIGI counts means, then this is something that they teach you as a trick when you're doing psychiatric mental health assessments. So let's talk a little bit about that. It's kind of like if you're doing an assessment and you can't remember what to ask, you're going to ask, have you had any changes in your sleep, which is the S? Have you had any decrease in your interest, which is your I? Have you experienced any guilt? Like, do you feel guilty about, your family having to pick up responsibility? Do you feel guilt that you're depressed? That's the G. The E is for energy, like decrease in energy or increase in energy. The C is for concentration. The A is for appetite. The P is for psychomotor retardation or agitation. And the S is for suicidal ideation. I would highly recommend you use Siggy Caps. To this day, I still use that. I'll make it a little note on my notepad just so I can make sure that I have covered each one of those symptoms when I am doing an assessment, because as you're going to see, these are the keys in diagnosing major depressive disorder. Which one of these are present and which one of these are not present? So back to the question. Okay, which of the SIGI CAP symptoms is the patient exhibiting? Sleep changes, interest, energy, concentration, and appetite. Now, the rationale, let's match the symptoms described to the SIGI CAP's mnemonic. Symptoms described in the SIGI CAP's letter explanation: difficulty sleeping, sleep changes, insomnia or hypersomnia are common in depression. Lack of interest in activities of friends, like loss of interest or pleasure, also known as anhedonia. Decreased energy and fatigue, that's the E. Energy, that's common in depressive symptoms due to low motivation. Difficulty focusing and completing tasks. C is concentration, decreased ability to think or concentrate. And then the A is for appetite loss or weight change is typical. Therefore, the patient demonstrates 5 of the SIGI CAPS components: sleep, interest, energy, concentration, and appetite. And on the boards, you can go back and look at the previous question if you needed to do that. So that's just a little tip. But again, the reason I threw this in there is SIGI CAPS is going to be something that you need to know for the rest of your nursing career. So this goes back to the question that we've already been asked. And on boards, you will see this. You will see 2 or 3 follow-up questions based on previous questions. So according to the DSM-5, which one of 2 specific symptoms must be present for a patient to be diagnosed with depression, and which of your patient's symptoms met the requirements. So the patient reports sleep changes, decreased energy, poor concentration, and a decreased appetite. So the DSM-5 requires one or both of the following core symptoms for a diagnosis of MDD: depressed mood, or markedly diminished interest or pleasure in almost all activities. Again, anhedonia. Know that word, you'll see it multiple times. So to meet DSM-5 criteria for major depressive disorder, the patient must have 5 or more symptoms from the CIGI-CAPS list during the same 2-week period, representing a change from previous function. I'll say that again. At least 2 weeks, they have to have the same symptoms, 5 or more. And at least one of those symptoms must be either depressed mood or a loss of interest or pleasure, the anhedonia. So as this applies to our patient reported sleep changes. He reported a decrease in energy. He reported poor concentration, and he reported a decreased appetite. These are supporting symptoms of depression, but the patient has not yet reported either of the 2 required core symptoms, depressed mood or loss of interest or pleasure. Therefore, based on the current information, the DSM-5 diagnostic threshold is not yet met until one of those 2 hallmark symptoms is confirmed. So let's go back to the core question. This is a 67-year-old male who's at the outpatient clinic, and he's saying he's having difficulty sleeping. He's not eating, decreased desire for food. He has a lack of interest in volunteering activities or going out with friends. That's anhedonia. And he describes difficulty in completing tasks due to fatigue and overall ability to focus. So do you see where he's not reporting depression? He's reporting sleep changes, decreased energy, poor concentration, and a decreased appetite. So he has not yet met the core diagnosis for depressed mood according to the DSM-5 criteria. You've already asked your patient about his symptoms. Next, you assess him for abnormalities in thought content and process. You ask him about this history with psychiatric practice and any treatment he has undergone for mental health conditions. You inquire about his medical history, including lab work, and any medications over the counter or prescription he is taking. And finally, you evaluate the patient for suicide risk. So now that you have assessed your client for major depressive disorder, check off all the items that you think that you have covered in your evaluation, and then we will review. So take a moment to read over each one of these and write down which ones that you think that we have covered in the evaluation. Okay, I'm going to give you a moment. All right, let's look at A, current stressors. So did you put down A as one of the ones that that we assessed? If you did, you are correct, because we did discuss current stressors indirectly through the client's symptoms and situational context. And then what about B, psychosocial stressors? That was also included as part of assessing his social support and activities. What about C, mental stressors or status? They were also evaluated through the assessment of thought content, process, concentration, and affect. And then what about D, past psychiatric history? That is asked about in the previous psychiatric treatment and diagnosis. What about E, family psychiatric history? That was not assessed, but it should be if it's not already included in the. And let me start over. That was not assessed, but it should be addressed. And if it wasn't already, then we do know. Then that is something that needs to be included in the follow-up evaluation. What about F? Other medical conditions. That was reviewed via medical history and lab work. And then what about G, the medication list? That was collected, including prescription and over-the-counter medications. And then what about H, other substances? That should be evaluated for alcohol, nicotine, caffeine, or illicit substances. That's going to be an important next step. And then what about I, suicide risk? This is one of the most important parts of the assessment, is explicitly evaluated as part of the risk assessment. Again, it's the most important component that should be assessed for. Suicidal thoughts are one of the most critical questions to be asked. And there are ways to ask this that is thoughtful and sensitive and can help the client to disclose in a truthful response. Suicide risk will be one of the topics that we cover in therapeutic communication, which is going to be one of the videos that's going to be covered over multiple series, because therapeutic communication is one of the most difficult, yet one of the most asked about topics on psychiatric mental health nurse practitioner boards. And then last, barriers to adherence, or J. That is something that we didn't ask about, but it will need to be explored. And these are things like factors such as cost, stigma, or side effects of medications. So this would be something you would need to cover in a follow-up visit. I can say that factors such as cost or stigma, those are something that I run into daily. Clients can't pay for the mental health visits, or they have stigma related to either culture that's related to their culture, or stigma that's just related to mental health overall in general. So that is something that will need to be explored later on. So out of A through J, which one of these did you put down as either we assessed or that we are going to need to be assessed? When you took the patient's medical history, he told you about some recent conditions, procedures, and medical conditions and medications. Which of these is likely relevant to his current depressed state? A, orthopedic surgery, B, myocardial infarction, C, discontinuation of simvastatin, D, increase in amlodipine. So, which do you think is the correct answer as we pause? The correct answer is myocardial infarction. And here's our rationales. Orthopedic surgery. While surgery can cause temporary stress or post-op pain, it's not a common direct cause of major depressive disorder unless complications of chronic pain develop. So B, myocardial infarction. Depression is common after a myocardial infarction due to both physiological changes like inflammatory and neuroendocrine stress responses, and psychological reactions to the loss of health, fear, and lifestyle changes. Post-MI depression occurs in roughly 15 to 20% of patients, and it significantly affects their recovery and their prognosis. Discontinuation of simvastatin. Statins are not typically associated with withdrawal-induced mood changes. Their discontinuation does not generally cause depressive symptoms. And D, increase in amlodipine. Amlodipine, which is a calcium channel blocker, can cause fatigue or dizziness, but it's not commonly associated with depressive mood or a loss of interest. So, some clinical insights regarding this is always screen for depression after major cardiac events like a myocardial infarction. Depression post MI can worsen mortality risk due to poor adherence, physiological stress, and lifestyle limitations. Integrating psychotherapy and pharmacological support like SSRIs are standard in post MI depression care. Now, if you're looking at these two and you're guessing which one of these could be, my guess is you narrowed it down to A or B. And you could argue orthopedic surgery, well, aren't they going to go through some of the same things that a myocardial infarction person is going to go through? Number one, you cannot argue with the boards. But number two, if you will go back and read the rationale, the answer is no. In myocardial infarction, your stress response is much greater than in orthopedic surgery. And remember that statistics, roughly 15 to 20% of patients significantly are affected in the recovery and prognosis after a myocardial infarction. Again, think like a psych MP, not like an RN. So for this question, we're going to be moving more along the line of medication. And medication is going to be some PowerPoints all by itself. Like we're going to do each section psychotropic medication. But here's a question to let you get an idea of where you are on understanding medication. Which of the following classes of antidepressants exert their activity by affecting more than one brain transmitter? A. Selective serotonin reuptake inhibitors or SSRI. B. Serotonin and norepinephrine reuptake inhibitors or SNRIs. C. Tricyclic antidepressants or TCAs. D. Monoamine oxidase inhibitors or MAOIs. So A. SSRIs or selective serotonin reuptake inhibitors. That is not the correct answer. They act only on serotonin by inhibiting its reuptake, hence selective. They do not significantly affect norepinephrine or dopamine. And you can think about that by thinking about it. Selective serotonin reuptake inhibitors. That is all they do. B. SNRIs are serotonin and norepinephrine reuptake inhibitors. That is the correct answer. And you should know that because why? They are serotonin and norepinephrine. So SNRIs block the reuptake of both serotonin and norepinephrine, increasing levels of these two neurotransmitters in the synapse. So examples of these, and I don't expect you to know that right now, but are venlafaxine and duloxetine. And then C, tricyclic antidepressants or TCAs. They inhibit the reuptake of serotonin and norepinephrine like SNRIs, but they also block histamine and other alpha androgenic receptors, which leads to more side effects. And this is like amitriptyline or nortriptyline. You don't even see these subscribed a lot. Amitriptyline you still do somewhat, but TCAs, so you should be, if you're looking at this, I would automatically say my choices are either A or B because TCAs, no, even though it says tricyclic, you might think, they they are only exerting they're exerting only one, right? Tricyclic antidepressants. And then D, MAOIs or monoamine oxide inhibitors. They inhibit the enzyme monoamine oxidase, which breaks down serotonin, norepinephrine, and dopamine, increasing all three neurotransmitters in the brain. And examples of these is phenylazine and tranylcycloporamine. Again, MAOIs you're very, very seldom going to see those prescribed. And as we're going to learn even later on in this presentation, there's a reason for that. They are so many foods that you cannot eat that if you're on MAOIs, that it makes it extremely dangerous. And those food limitations make it almost impossible to admit those from your diet. So D should be one that you automatically say that's not the answer. Next slide. Now, if you have ever sought treatment for mental health or you've ever been on a psychotropic medication and it's the first time, then you probably know the answer to this one. Which of the following are recommended as first line for the treatment of major depressive disorder? A. Selective serotonin reuptake inhibitors or SSRIs. B. Serotonin and norepinephrine reuptake inhibitors or SNRIs. C. Tricyclic antidepressants or TCAs. Or D. Monoamine oxidase inhibitors or MAOIs. So, based upon the previous slide, we already know C and D is not the right answer. And why is that? Because MAOIs, there's so many foods that you cannot eat that they pretty much are not prescribed anymore. They're really dangerous also. If you overdose on those, then they're deadly. So those are not even hardly ever prescribed anymore, especially to somebody that's depressed and suicidal. Tricyclic antidepressants, again, we already said we don't see those very much anymore, right? So that leaves us with A and B, SSRIs and SNRIs. So which of the following are recommended for the first line for treatment of major depressive disorders? The answer is SSRIs. And that will always be the case. If you have somebody that comes to you that has never been on a medication, there's an algorithm that we follow, and we always start with an SSRI. And if you're not familiar with that, that's going to be like fluoxetine or Prozac. And that's another side note here when we're going over these drugs. Always know both names of the drugs, but you need to know fluoxetine. I think the boards has now changed to where they do list both names of the drugs, but when you're in professional circles with other psychiatrists or psych MPs, we are not going to call fluoxetine Prozac. We're not going to call Zoloft. Um, we're not going to call sertraline Zoloft. We're going to use it by the name that it's known as. So SSRIs like fluoxetine that or sertraline, those are first line for treatment for major depressive disorder. And this one we've actually already discussed, so I'm going to read you the question and let you pick out the answer, and we don't even need to explain the rest of them. Which of the following require the patient to follow a straight dietary restrictions? A. SSRIs, B. SNRIs, C. TCAs, or D. MAOIs? Give you a moment to think. And what's the answer? MAOIs. And why is that? Because there's so many food restrictions, and we're going to talk about what those food restrictions are later on in this presentation. In evaluating your patient, you've learned that he has a history of high blood pressure. Which medication might pose a risk for this patient? A. Citalopram or Celexa. B. Paroxetine or Paxil. C. Venlafaxine or Effexor. D. Vilazodone or Vibrid. And E. Vortioxetine or Trintellix. The correct answer is C. Venlafaxine or Effexor. So let's talk about the rationales for this. A. Citalopram or Celexa. This is an SSRI that primarily increases serotonin. It has minimal effect on blood pressure, but it may prolong QT interval at higher doses, but it's not typically a concern for hypertension. And then we have B, paroxetine or Paxil. This is also an SSRI that has an anticholinergic property, but it does not elevate blood pressure. It may cause weight gain and sedation instead. And then we have C, venlafaxine or Effexor. And this is the correct answer. So, venlafaxine is an SNRI that increases both serotonin and norepinephrine levels. The norepinephrine reuptake inhibitor at higher doses can lead to a dose-dependent increase in blood pressure. That's a key concern in patients with hypertension. So, monitoring of blood pressure is essential during therapy, especially when you're at levels of above 150 milligrams a day. And then the next one, vilazodine or Vibrid, that acts as an SSRI and a partial 5-HT1A receptor agonist. And remember, we're going to talk about 5-HT1A receptors later on, and all kinds of receptors, because those are on the boards. There are so many of those questions on the boards about which drugs do and do not affect which receptors. And in the real world, I call it in the real practice, we can have a sheet that has that on it. We can know it. We can look in a book. But on board, you have to memorize this. So remember that. Vibrid, it acts as an SSRI and a partial 5-HT1A receptor agonist. So it does not affect norepinephrine and is generally neutral on blood pressure. And then E is Trintellix. Trintellix is an antidepressant that affects serotonin receptors and reuptake, but not norepinephrine, so it has no hypertensive effect. So just some clinical insights about this question. When treating major depressive disorder in patients with hypertension, avoid or use caution with SNRIs due to possible blood pressure elevations. Opt instead for SSRIs like sertraline, citalopram, escitalopram. Those are all rather cardiovascular safer options. Which of the following statements about antidepressant medications is correct? A. Bupropion or Wellbutrin is contraindicated in patients with seizure disorders. B. Fluoxetine, Prozac, has the shortest half-life of the SSRIs. C. Venlafaxine or Effexor commonly decreases blood pressure. D. Trazodone, Deseril, is most associated with significant weight gain. Or E, amitriptyline or Elavil has the lowest anticholinergic activity among antidepressants. So let's pause for a moment while you look at that. Which of the following statements about antidepressant medications is correct? So A is the correct answer. Bupropion or Wellbutrin is contraindicated in patients with seizure disorders. So bupropion lowers the seizure threshold, making it contraindicated for patients with seizure disorders or eating disorders, such as bulimia or anorexia nervosa. B, fluoxetine, Prozac, that's incorrect because fluoxetine actually has the longest half-life of all the SSRIs, up to 4 to 6 days, with its active metabolite, neurofluoxetine, lasting up to 16 days. The long half-life reduces withdrawal risk, but it increases interaction potential. And that in of itself would probably be a board question. Always remember, fluoxetine has the longest half-life. Because as in this example, that sounds like a good thing, but in some cases it can be a bad thing, right? C, venlafaxine or Effexor. While venlafaxine is associated with dose-related increase in diastolic blood pressure, it's not decrease. So you want to monitor the blood pressure, especially at doses above 150 milligrams a day. Now, this is where you could see A and C as narrowing it down to your two that you're like confused about, right? Trazodone or Deseril is incorrect. Trazodone is not known for weight gain. It's mostly associated with priapism or prolonged painful erection and sedation. And then finally, amitriptyline or Elavil. Um, so while venlafaxine may raise the may raise your blood pressure, amitriptyline is more likely to lower it or cause orthostatic hypotension and cardiac arrhythmia problems. So let's talk about some key clinical takeaways with this question. Avoid amitriptyline in patients with cardiac disease, conduction abnormalities, or arrhythmias. Elderly or fall risk due to the hypotension and sedation effect. You want to monitor the EKG before and during use in patients over 40 years old with cardiac history, and use caution when combining antihypertensives because it can potentially lower your blood pressure. Which of the following medications or substances may result in serotonin syndrome when combined with serotonergic antidepressants such as SSRIs, SNRIs, TCAs, or MAOIs? A. Phenelzine. B. Linezolid. C. Valproic acid. D. Tramadol. E. Sumatriptan. F. Cocaine. Or G. St. John's wort. The correct answers are A, B, D, E, F, and G. So let's talk about the rationales behind that. A is an MAOI inhibits serotonin breakdown. Combining with serotonergic agents like SSRIs, NRIs, TCAs, or certain analgesics can cause dangerously high serotonin levels, or that could be serotonin syndrome. B. Linezolid. Linezolid is an antibiotic that acts as a reversible MAOI, so it can increase serotonin and participate serotonin syndrome when used with SSRIs or SNRIs. C. Valproic acid, that's a mood stabilizer and an anticonvulsant, and it does not increase serotonin. It is safe with SSRIs. D. Tramadol, it's an atypical opioid that inhibits serotonin and norepinephrine reuptake, increasing serotonin levels and the risk of serotonin syndrome. E. Sumatriptan, that is a 5-HT1B 1D receptor agonist that's used for migraines, and when combined with SSRIs or SNRIs, it can cause serotonin toxicity. F. Cocaine. That increases serotonin, norepinephrine, and dopamine through reuptake inhibitions, and combining that with SSRIs or SNRIs can also lead to excess serotonin. And G. St. John's wort. That is an herbal antidepressant that enhances serotonin levels, and that also combined with an SSRI or SNRI can cause serotonin syndrome. This is an important question because St. John's wort can be purchased over the counter, and oftentimes when you're doing a history on a patient, they will tell you that they're taking St. John's wort because it has been shown that it can improve depression. And if they are on St. John's wort and you give them an SSRI or an SNRI, then it can possibly cause serotonin syndrome, and serotonin syndrome can lead to death. So it's extremely important to obtain a history and get a list of both over-the-counter, prescription, and even illegal substances that are taken, like cocaine. So we have reached the conclusion of today's psychiatric mental health nurse practitioner review. If you have topic suggestions or questions, please drop them in the comments. I always love hearing your ideas. And if you're interested in one-on-one tutoring or you want to learn how to start your own private practice, please email me at the email below. I do offer one-on-one tutoring. So if that's something that you think that that you're interested in, maybe you have already failed your boards one time, or maybe you're just feeling very weak in these areas, I would love to meet you and offer you some tutoring. Again, thank you so much for watching. I hope that you are learning from this content. If so, please don't forget to like, subscribe, and share it with your co-students and anyone you know that may be preparing for the boards. I look forward to seeing you in the next Psychiatric Mental Health Nurse Practitioner Review.